Um, Thanks, everyone, and warm welcome to our webinar for today on the future of the health sector in Syria, which is not an easy task to even think about it, let alone for those ones who actually have to do it. But it's great that we could come together and give it some thoughts and maybe come up with some recommendations. My name is Egbert Zonder. I'm a member of the thematic working group on health systems in fragile and conflict-affected settings, which is one of the 10 thematic working groups within the larger Society of Health Systems Global, the organizer of the biannual Health Systems Global Research Conference. Together with Ibrahim Bououm, we will moderate this session, and we will be joined by a number of panelists, both to give a few short presentations and then have a discussion. And then later on, we give you also not the floor, but at least we give you the chat box to come up with comments, questions, suggestions, whatever. And we will try to handle these through the panel. Let me first introduce you a bit more about our thematic working group. Which is this slide. So as I said, we are a thematic working group, quite an active one. I must say, it could always be better, but comparably, we are quite active. We have over 2,000 members on our different lists, and we try to connect researchers, policymakers, donors, and all the other people involved in the health sector, in particular with a focus on fragile and conflict-affected states. We try to connect people, share knowledge, do some advocacy for health systems research in FCAS, and also contribute to capacity strengthening. This is a number of links how you could link with us. If you're new to us, the most easy one is to have the email at the bottom. The other ones you can use them. We had promised to share this slide with you. I'm not sure how we're going to do this, but maybe if Karen hears us, she may be able to post it in the chat. I'm not sure. In any case, we will share the presentation, the whole webinar of today with all of you as soon as possible after the end of this session. So it will be available on the Health Systems Global website. So this is an example of what we do as a thematic working group. We produce a bi-monthly newsletter. We have what we call a talking points webinar series, which this is one of them. It took a while because there was an internal process within HSG to refresh, as they call it. And this is again is the first in the new cycle of our lives as a thematic working group. So what we have already have started, we have a call for contributions on the topic of aid-induced fragility of health systems and plans to develop a number of policy briefs about this topic, which is so close to us these days, and also collectively prepare collage through Collage Collective, which will be presented in Dubai. That leads me to the last point. We are also contributing to the preparations, both of the conference itself, but also to presentations for the 9th Global Symposium on Health Systems Research, which will be held in Dubai a year from now, which is almost around the corner. Always, as it goes, time flies. What we want to do as TWG in preparation, also together with our members, to have, we hope for a hybrid or otherwise a virtual pre-conference on specific our topics, which are dear to our heart on the fragile conflict-affected states. So this, so that we can talk amongst each other, and then the outcome could be then shared during the meeting in Dubai. More news to follow probably in January or February. So that leads me to what we want to do today. We want to discuss the current situation and dynamics of the Syrian health sector. We'd like to analyze potential scenarios for recovery and rebuilding of the health sector in this very complex environment, discuss opportunities and challenges to integrate the health systems, because most of you probably know there are different areas in Syria up to the recent events and the change in regime, and see how that now goes. We would love to hear more from the speakers and the panelists. And then at the end, maybe not today because it may need some reflection, but we are planning from this webinar to produce a blog, and that should have a number of recommendations to inform the health sector. So we have, as panelists, we have two people we asked to give a brief presentation. One on the generic situation at the moment in the health sectors, Christina Betke, the acting WHO representative, and the other one is based on a specific study which was done by the Kid Institute in the Netherlands, and which will be presented by Edel Jacobs. And then we'll have a few other panelists you will see, and they will be introduced by Ibrahim, who will lead the panel. So this is the agenda. We start with these two brief presentations. Then we have 2 rounds of questions and interventions from the discussants. So round 1 will be about the current and emerging dynamics as it is now. And the second round will be more focused on the future, to think about pathways, barriers, and enablers for the health system recovery. Then we have a Q&A session, as already mentioned. And please, if you have any questions, comments, suggestions, whatever, please put it in the chat box, and we hope to get back to it in the panel discussions at the end. And be aware that, as I said already, that we do share the whole session, just record it, and we will post it as soon as we can at the HSG website, where you can find it. So this is to introduce Christina. Christina is the interim WHO representative in Syria at the moment. And what we do now, I will stop sharing, and she will share her own slides, and then you will hear her talking if all goes well.
Alrighty, well, thank you for giving me the opportunity to speak today. And I'm speaking to you from Damascus, and I will give you just a very brief overview. There's so much to say about the Syrian health system, and I believe that a lot will also come out in the richness of our conversation. So just to walk you through a bit related to our situation on the ground, obviously very high levels of damage, but not just that, also chronic underinvestment over the decades, not just during the crisis period. Additionally, of course, donor red lines historically during the crisis period prevented any substantial infrastructure and equipment inputs, and then sanctions themselves made it very difficult to keep spare parts in hand, to keep equipment running, to run software updates, etc. These 2 maps here really point to the fact that it's not a uniform challenge across the country. These come from the World Bank recent report that was released at the end of October. On the left-hand side is non-residential sector physical damage. They didn't break it down by health, education, etc., but these are considered actual buildings and other forms of infrastructure that support different sectors. So you can see there a varied pattern, and likewise on the right-hand side is infrastructure like water, electricity, roads, etc., which are indeed enablers for the health system. And therefore you can see that recovery will be a mixed picture across the board, and it will also in some cases map very heavily to where communities and individuals are returning. Aleppo is an area of high return, rural Damascus is an area of high return, and Damascus itself. And so how those patterns of population movements will potentially cause additional strain on an already disrupted health system is worth keeping in mind. In terms of public facility functionality, those of you who've been following the Syria response for a long time know that HIRAMS has historically included both NGO-run facilities in the Northwest and public facilities across the country. This is just the public facilities at this time, not discounting the NGO inputs, but just to be clear about what the status of the public sector looks like. And there you can see that just 58% of the hospitals and 23% of the PHCs are fully functional within the public system. The links to these HERAMS dashboards also are in the titles of hospitals and PHCs, so you'll be able also to dig in a bit more detailed across the board. But it really speaks to what is the probability when someone goes to a health facility that they're able to actually get the services they need at any given time, particularly as we look ahead to hopefully expanding universal health coverage. PHC model and PHC points of entry are perhaps some of the least functional at this current moment in terms of what we're building towards, but also to keep in mind about what public trust looks like historically in the system, noting the functionality status. From the perspective of disease surveillance and response, we've also historically had two surveillance systems in the country, eWARS and eWARN. Right now, together, and I want to say all of this is in partnership with the Ministry of Health, but we're in the process of, together with the MOH, trying to integrate those two data collection systems into a single system. And then the second phase is really migrating that towards integrated disease surveillance. I will note that over time, we've had the eWARS, eWARN, but we've also had separate data collection systems for things like vaccine preventable diseases, HIV, TB, et cetera. So really moving towards an IDSR model, integrated disease surveillance and response, is really the longer term goal. You can see there on the right-hand side is the eWARS dashboard. So this is about 1,300 Sentinel sites. We have an additional 300 Sentinel sites approximately with eWARN that are regularly reporting. Don't want you to worry that suddenly on the right-hand side that we've had a major issue with completeness. There's about a 2-week delay in terms of the dashboard entry. So that blue line should come up. But what you can see there is most of the time we're above 80%, which is the sort of the threshold that we hope to maintain. And across the country, despite the change in governance and the need to keep the systems running, especially eWARS, which is directly in partnership with the MOH, these systems have prevailed over time, even amidst political transition. There's efforts ongoing to migrate from paper to digital, which is a big jump, of course, not just training, but also all of the devices, the connectivity, et cetera. And also to pilot and roll out event-based surveillance and electronic information systems to actually try to use online social media and other sources to detect outbreaks of disease and other events as well. And then with laboratories, it's a bit of a difficult picture. The Central Public Health Lab is operational, but there are limitations in its capacity. And then at the subnational level, the need to ensure that we have capacity at a decentralized place so that we're able to more quickly collect and determine and identify any potential disease threats is ongoing. In terms of supply chain, big gaps in cancer medication and NCDs, but they're working to regularize LMIS and also procurement, it should have said. These are bigger long-term issues. The pharmaceutical industry as well, and I'll talk about that in a second, has been heavily disrupted. Prior to the crisis, there used to be about more than 70 facilities that were producing medications locally and covered the vast majority of Syria's needs. At this time, however, less than 40 are really up and running, but that's increasing with time. For workforce, we know that up to 70% have left the country. There's varying statistics that have been used over time. We are seeing gradual return, but I will say that because the enablers of return, like shelter, water, electricity, etc., education for family when you come back, are still not fully in place in all areas, there's a bit of a delay in terms of people fully being ready to return. The salaries question is something that also it needs attention. There's certainly, because we had a country that was divided at one time, there's different scales in use, and the ministry is doing its best to take a look at what that looks like. I'll talk about that in a second. And then finally, disrupted education patterns. Which institutions did people get trained in? Was that education completed? Was it actually an evidence-based curriculum, etc.? Do we mean the same thing when someone says, I'm a nurse, for example? In terms of governance, we continue to see leadership and management challenges and the rebuilding of capacity at national and subnational levels. That's not to say there's not a commitment to wanting to address that, but there is a rebuilding that has to take place across all levels of the government, and that's not limited only to the Ministry of Health, of course. With data, there's a number of gaps that are in place, again, because there were different data collection systems over time, different instruments were used, and even a lot of the national estimates prior to the change in government in December were largely based upon areas under the control of the former regime. And so therefore the need to refresh all of those population-based indicators is very strong. I will say that there's a number of assessments ongoing which should help. The first one is the SARA, which will help us understand a lot about health system access and functionality, health labor market analysis, GIS accessibility survey, EPI coverage, and SMART survey. And then there's a number of planned assessments that are coming up, hopefully, and that will be stepwise, looking at the picture of NCDs, JEE and NAPS for those who are Joint External Evaluation of National Public Health Security, and then MIX. And then finally, in terms of where we are funding wise, we don't yet have a figure for what does the health system really need to actually provide all of the services, all of what is the package, etc. So sort of cohesion of policy and costing isn't there, but we can say from the humanitarian side of the house, only about 20% of the 565 million that is needed for 2025 has been received. Now, often we see that sort of go up a bit towards the beginning Q1 of the following year because there's delays in reporting funding, but still that's a significant gap, as you can see, in terms of what has been until last year the largest source of support to the continuity of essential health services in the country. In terms of what coordination looks like, it's refreshing to be able to say, really, the government is the starting point now, and that we see that there's departments of international cooperation and departments of planning within the MOH, and those plug into the Ministry of Foreign Affairs. So really, we see across different areas of government the effort to ensure that this isn't just siloed within one ministry or approaches aren't scattered, but there's actually a coherent approach to try to ensure good cooperation and good planning. On the humanitarian side, the health sector continues to operate. It's co-chaired by WHO together with the Ministry of Health at the national level and the Directorates of Health at the subnational level. Today, there's about 120 different partners, from national NGOs to international NGOs to observers to donors, etc. Also a set of working groups for MHPSS, risk communication, community engagement, reproductive health, and trauma and disability. I will note that previously there were more working groups up in the Northwest prior to the sort of merging of the country, but now those are the primary ones that are operating still. For the early recovery and development space, the coordination mechanisms are still emerging across the Ministry of Health, partners, and donors. But I will say so far there's key areas of focus that we're hearing consistently from recovery and development entities, mainly focusing on things like health finance, health workforce, universal health coverage, infrastructure, revitalization of the pharmaceutical industry, and governance. And I really want to say, it's a bit of a difficult picture in the front side, but there's actually a lot of progress being made. And I want to be sure that we're sort of balancing our perspectives, especially since we're talking today about what does recovery and resilience look like in Syria and what can we do more of. So first and foremost, we see a very high level of government ownership. And that is really, it comes through, it's apparent, and the involvement and the leadership of the Ministry of Health and also Ministry of Higher Education and the relevant aspects continues to be very strong and very much forward-facing. There's also the release of a 2-year strategic plan for a national health sector, and there's 7 pillars. You can see them on the right-hand side there, which are featured, and I believe that that will soon be sort of debuted more widely. It's already been shared with the health sector, and I think will become sort of endorsed very soon, at least by the Ministry of Health. We also see a joint commitment between the Ministry of Finance and the Ministry of Health to engage in the Universal Health Coverage Compact, which is, I don't want to spend too much time on it, but is a sort of high-level political commitment through an instrument that is supported by the government of Japan, World Bank, and the WHO to say this is how the country intends to achieve UHC over the coming years, and here's the interventions and approaches that they will use. See high levels of interministerial cooperation across the board and a prioritization of health and education budgets, which is really encouraging. Efforts are ongoing to raise salaries, and really the government-wide revitalization and centralization of information, data, and statistics with an embrace of evidence-based approaches and data-driven approaches, which is really encouraging to see. I don't want to spend too much time because I understand we're short, but just you can see the slides later. Also, we see a lot of reactivation, hospitals, PHCs, ambulance capacity, and specialized things like smoking cessation. So really, although we do see, functionality of public facilities is still needing to expand further, we do see a lot of efforts to in real time over the past year to further expand the public capacity. So just before I close, to say that any evolving context here and any plans moving forward, we really need to be thinking about flexibility and just cross-cutting capacities across the nexus, because risks and hazards are still enormous. We did a STAR exercise about 2 years ago, and when you look through the 17 high-risk hazards that were identified across whole of Syria, only a few of them have been removed since the 8th of December, and plenty are still in place. Displacement already, we've had returns of almost 3 million between IDPs and refugees, and over the next 12 months, probably an additional million to 1.5 million people projected. Still, those enablers like water, electricity remain disrupted, and so although there are ongoing efforts to strengthen those, they are still impacting the health sector. The political and security landscape is still evolving. All of you, I'm sure, have plenty of Google feeds and news feeds, so you know the background of that. The economic gaps that we see, both in terms of the market capacity, but also in terms of individual patients' ability to access services while the delivery system is still recovering. And then the growing diversity of stakeholders, because now it's no longer just humanitarian actors plus government actors. Now we see many different private sector has always been a big player in the health system, but there's increasing investment and outside interest in how external actors can be involved in the private sector in Syria, as well as, of course, development, early recovery, etc. So that diversity of stakeholders is both a blessing, but also potentially a risk if not managed well. So in conclusion, I will just say that I think across the board, and I really want to commend the government themselves also to really recognize that the restoration of the health system lies at the heart of recovery, stabilization, and resilience in Syria. And we understand, and I think there's a shared perspective across a number of actors, that sustained support to health really underpins peace building, returns, and social cohesion. That these HDPN approaches, and I'm excited to hear the conversation today, really are critical to bridging this transition period. And the different areas of Syria, as you saw in the very beginning, and the maps that we showed, not every area of Syria is the same. So it's going to require some bespoke approaches, as well as tailoring to the different areas. We see already that government ownership is essential, and it's really going to be the backbone of resilience and sustainability. and that we need to make sure that whatever we're doing, we're operating from an area of prioritization and sequencing, because the order of how we do things, and when I say we, it's not WHO, it's not everyone here, the ministry, all actors, is going to really determine how impactful we are. That our global evidence and our country and regional lessons learned should be consulted, but then also adapted. And we hear this again and again from our colleagues in the Ministry of Health, eager to learn of lessons from other places, but also wanting to make sure that it truly reflects the unique context of Syria. And then finally, to conclude, that working in partnership and working in coordination is not something that can be considered a luxury. It is an absolute necessity where we see resource scarcity across the board, but also the risk of discoordination and the harm that could cause. So I'm again excited to see the conversation today and how we can better collaborate and support the vision of the Ministry of Health and the people of Syria for their recovery. Thank you so much.
Thank you. Thank you so much, Christina. This was an excellent introduction, and yeah, a bit to my surprise, a relatively optimistic talk. I hadn't really expected. So that's good to hear from someone who's really inside. And I also could imagine that you have a lot on your plate, because it will be a challenging time and not everything will run smooth, as we know from other areas. So thanks for that. Start, and we'll hear from other voices if they share your feeling about the situation or have some other concern which is likely. So I will now start sharing the slides at my hand and see if we can have it big, because I want to introduce Elko. I think you do see some, but it's not enlarged yet. It is. There's progress, as in Syria, there's progress in our webinar. That's good. So let me introduce Elko. Elko is working at the KIT Institute in Amsterdam. He is a specialist in health systems governance, policymaking and financing, and a researcher at that institute. And together with others, including Olivier Onvlé, who is also with him today, they will present a specific study they did in the human health force and the political economy thereof, of the study itself. So let me see, Elko, the floor is yours.
Thank you very much, Egbert, and thank you for the opportunity, also to the organizers for presenting this. And also thanks, Christina, for the excellent, sort of setting the scene on the situation in Syria today. Indeed, I'm presenting results, insights from a study here, a political economy analysis of the health workforce data governance, a study we conducted in northwest Syria a year ago exactly. And as we were sort of finishing up, the whole situation changed. But still, our insights hopefully still have some use for the situation today, because also things are changing, luckily, but some certain power dynamics, institutional structures, and interests also don't change overnight. That's actually at the heart of this presentation that I've titled "Information is Power and the Power Behind Data." I'm joined here, as Egbert said, by my colleague Olivier Onvlé, because we conducted this study together, and yeah, he was as much part of the study as I was. Let me proceed now. Egbert, next slide. Thank you. Maybe first to set the scene. Of course, we all know there was a conflict, a long, damaging, painful conflict that concluded, we could say, at the end of last year, but resulted in real fragmentation of governance in the Northwest. The whole North, perhaps you could say the whole country, but we're particularly focusing here on the Northwest, where sort of at the end, we'd find two rival groups claiming government legitimacy, the Syria Salvation Government and the Syria Interim Government. And in terms of health workforce management and health workforce data control, we saw several semi-independent health directorates effectively taking charge in that domain. But also we saw Turkish health directorates from the border provinces exerting great degree of control. When it comes to the health system at that time, in that context, it was actually not really possible anymore to speak of a public sector. All facilities were essentially NGO run or commercially, privately run. But that private sector, the commercially run private sector, really was sharing very little information on its health workforce. And the information there was channeled by the NGOs running them in collaboration sometimes, or in a fragmented manner by the health directorates. But overall, you could say there was not really a clear overview of the composition of the health workforce available. Egbert, next slide, please. So by 2023, 2024, the country and the region faced decreasing donor interest really in this conflict and the health system needs. So there was more and more of an urgency felt of optimizing the workforce, seeing how the workforce could be strengthened with also all the challenges that were there, with all the damaged infrastructure, many health workers that fled the country. And the need for a mapping of the health workforce arrived on our plate. We were requested by the EU delegation to Syria to conduct such a health workforce mapping exercise. But we realized very quickly that it was very difficult to do so because data systems were highly fragmented, inconsistent, and above all, also very politically contested. And that really impeded our understanding of the health workforce. Yet effective health workforce governance relies on reliable data for planning, development, and management. So you need the data for good governance of the health workforce and optimizing strategic planning of the health workforce. But because of the fragmented nature of the governance, and fragmented data systems, this was almost an impossible task. So we realized we really had to start with that whole governance landscape and understand the power relations, incentives, and institutional arrangements that shape health workforce data, to then ultimately give some insights and suggestions for supporting and strengthening health workforce systems. Now, of course, the situation has changed, luckily, but so some of the results are a little bit outdated. But try to also, or I'll try in this presentation also to offer some insights that are broader than the situation, of 2024, and that can still be used to strengthen the health workforce and health workforce data systems in Syria today, and indeed beyond in comparable fragile and conflict-affected settings. Next slide, Edward. What we did was a qualitative case study, mostly relying on interviews and focus group discussions, with a focus on exploring those stakeholder interests, power dynamics, and institutional structures. Next slide, please, Egbert. We were in search for a good framework to help us make sense of the results, and even just help us guide the interviews, trying to see how do we make sense of this data governance or health workforce data governance landscape. And there wasn't really an adequate framework in place. So we devised a new framework based on existing frameworks, looking at sort of the data management cycle and health workforce governance and of course, we found a lot of we found a lot about like how the data management cycle works. So creating data, processing it, storing, transferring, analyzing, and archiving health workforce data. But those results are so specific and granular. There's not really time for that. So I focused mostly on the health systems governance dynamics that are of relevance to this health workforce data governance situation. And so the rest of the presentation will go into that mostly. Next slide, please. So it's important to be mindful of the fact that data governance dynamics actually reflect broader struggles for legitimacy and power. And if you want to identify those data power dynamics, there's sort of three main questions that are helpful in asking. Who collects what data? Who accesses and uses data? And who benefits from data? And particularly when it comes to sort of the interests, it's important to realize that data is not just neutral, or not everyone's always only interested in using data as evidence for technocratic decision making, but it's also a means of control and indeed legitimacy for groups that claim government authority. And in Northwest Syria, we really realized that this data governance is actually political governance. So control over information reflects that control over resources and legitimacy, claims to legitimacy. At the same time, competing authorities and donors also, we found, actually reproduce fragmentation by asserting data ownership. And it's very encouraging to hear that there is more recognition of the need for coordination and strengthening data systems. But what we found here is that, all different groups demanding data and sitting on their own data was also a way of asserting their own claims to power. And we found that health workforce data collection was not just conducted for the sake of gathering the right evidence for decision making, but also serving as a way of exerting political oversight. Next slide, Egbert. Could say we concluded eventually that in the case of Northwest Syria, there's really a case of sort of network governance, governance operating through sort of loosely connected networks of NGOs, local directorates with varying degrees of control over data and the health workforce. The rival proto-states of the Syria interim government and Syria Salvation government, and other quasi-authorities. And particularly through the instruments of licensing the health workforce, regulating it, and also regulating their salaries through setting standards for pay scales, were really instruments of power and statehood also. If you're seen to be the one regulating pay scales, you're also the authority, right? And at the same time, as I already mentioned, local directorates continued to function to varying degrees, which also showed the institutional legacy from pre-war structures. And to a certain degree, that also provided continuity to the system, and hopefully also a basis for further recovery. And particularly noteworthy here is the Idlib Health Directorate that sat in the territory of the Salvation government, but actually functioned with quite a high degree of autonomy. And they were quite crafty in negotiating their autonomy and continuing to be seen and to be accepted as a sort of technocratic body operating in a highly politicized field. But in the middle of all of that, health workers had to navigate, and health providers to navigate multiple reporting lines, let's say to a health directorate, to a quasi-government to donors and NGOs, shaped by these different funding flows and administrative permissions, including licensing, etc. Egbert, next slide, please. And yeah, I already touched upon some of the external actor politics. You see a very old example of external actor politics with a picture of the one of the Crusader forts in Syria. But we found that several actors exerted a high degree of influence here. WHO, particularly as sort of convener of the Syria Health Cluster, GIZ, and a range of international NGOs, several of them operating also from Turkey. We'd all be managing separate health workforce databases, but with rather minimal coordination between them. And they were doing so through their reporting requirements that actually was driving duplication, fragmentation, again with limited data sharing. And the focus of this reporting and the health workforce data gathering drive was mostly on preventing dual practice and fraud, which actually went to quite an intrusive, or the degree of monitoring was really touching upon or raising some privacy and GDPR concerns in terms of how intrusive the questions and the level of detail was that was required from health workers to report on. Also quite noteworthy is the influence of Turkey. That was only something we found out after quite a while, that provincial health authority task forces were set up, linked to bordering neighboring provinces in Turkey, so Hatay, Kilis, and Gaziantep, for example, and they'd be linked or paired with Syrian districts to provide technical assistance, but also rivaling in a way for example the pay scale harmonization effort by the Syria Health Cluster with its own salary scales, and expecting NGOs operating in those contexts to adhere to those pay scales that were different from WHO, from the Syria Health Cluster's pay scales. But also sort of approval for operating in those areas, and the operations of the different NGOs supporting health providers in those districts. We found diaspora specialists and diaspora groups still to be very engaged with the health sector, obviously with an intent to continue to support and run health services in northern Syria, but particularly health specialists were quite dominant there, which inevitably went a bit at the expense of strengthening primary healthcare. And what you can conclude from all of that is that health workforce data is often used as a mechanism of control, rather than that data was really gathered and used for strategic planning of the health workforce, also because of its fragmented nature. Next slide, please, Egbert. So this brings me to the last slide, some key takeaways for strengthening health workforce data governance, or indeed health data governance or health workforce governance in comparable settings. So it's an important message from our study that data ownership can be a political tool or ploy. And if authorities or groups are asked to relinquish data control, for example, in a move towards centralization, you're asking them also to relinquish some claim to authority or power also. Now, and if you want to do so, there needs to be quite a degree of trust between actors. So trust, health data sharing, coordinating, aligning to different data systems requires trust. And without trust between those actors, because it's actors and people with interests that manage those systems, even technically sound data systems can fail. So that shouldn't be underestimated. It's very encouraging to hear that there is a drive towards greater coordination, because fragmented governance really undermines systematic data use for decision making. It's very inefficient and prevents strategic planning. Also, one needs to be mindful of market and elite interests shaping the workforce composition. If there is a lack of strategic planning, inevitably, for example, the private sector interests take over, or those that have a high degree of influence in the system because of their elite status. So technical solutions alone are insufficient. Again, that's sort of repeating that technically sound data systems alone are not enough. And in all of this, also, when you're dealing with data, you need to also think carefully about ethics and security, particularly in conflict times. Some privacy of health workers needs to also be really considered, because we've seen, particularly during the conflict, a lot of attacks on health workers associated with competing groups of power. It's very understanding that there's still high degrees of maybe distrust in the system because of those traumatic experiences. So data privacy and security really should also be considered when considering the need for transparent and strategic workforce planning. Thank you. I'm concluding here.
Yeah, thank you very much, Ilko, for this interesting study. And I can clearly see that some of the things which you have done in the Northwest, but they have relevance for the wider picture as it is today. So I think that's great to share this with all of us. So it's time now to move on. Thanks to the two presenters to give us a bit of a background. And now I would like to give the floor to Ibrahim, who will lead the panel. So this is Ibrahim Bououm. He is currently based at Liverpool School of Tropical Medicine. And yes, Ibrahim, the floor is yours.
Thanks so much, Egbert, and thanks really for the presenters for setting the scene and really tell us about the challenging dynamics in the current health system, from the infrastructure figures that Christina shared, and also broader elements of each element of the broader issues with each element of the health system before hearing from Elko. So we have 2 rounds. We're a bit behind schedule, as you can imagine. So I'll start with the first round, where we'll continue the diagnosis part and then try to understand more about the current state of the health sector in Syria, and then move on to a second round where we kind of try to have a future-looking approach, where we look at opportunities for recovery and try to do, if we can, quickly, with the time allowed, if time allows, to a priority kind of a exercise. So I'll be joined by 3 panelists for the first round. So I'll introduce them all, perhaps, and then we don't stop the discussion. So first, and I'll introduce them as they will answer the question, so in the same sequence. So first is Dr. Abdou Sebushishi, who's joining us from Kigali, if I'm not mistaken, today. And then he is the Senior Global Health Advisor with IMC, with the International Medical Corps, where he provides technical support across Middle East and Africa regions. He has over 14 years of experience in crisis settings. He has worked in DRC, Afghanistan, Liberia, Rwanda, Sierra Leone, and South Sudan, and he played a key role in epidemic preparedness and response efforts, and served as the national co-lead of case management and development of South Sudan national strategies. He leads the technical support for health system recovery as well from the side from IMC side in countries such as Syria, and now he's engaged with collaborative design of IMC health sector recovery program with the Ministry of Health and local civil society partners. So thanks so much, Abdul, for joining us. And then after I'll have our dear colleague, Professor Fuad, who's Professor of Social Sciences and Global Health in the Department of International Public Health at Liverpool School of Tropical Medicine, LSTM. And he also serves as an adjunct professor at the American University of Beirut with a nearly 30 years of experience in research programming and public health leadership. He has worked across academia, NGOs, and government institutions, and the research primarily, Fuad's research primarily focuses on migration and health concerning especially forced displacement health system in crisis situation and multidisciplinary approaches to humanitarian challenges. And he has contributed to global health policy by serving as commissioner on many Lancet commissions. And then also in this panel, I'll be delighted to have our dear colleague, Dr. Ali Ardalan, who's a global health expert with over 20 years of experience in various policy-making, managerial, advisory, and academic roles. He's currently with the WHO EMRO. He serves as the regional advisor and the head of Health System Resilience Unit at the WHO Regional Office for the Eastern Mediterranean, and he focuses on health system recovery from emergency and the operationalization of the humanitarian development peace nexus. And he worked a lot on the health of refugee and migration and building health system, resilient health system by integrating health system and health emergency risk management. So again, he was the founding chair and professor at the Department of Disaster Public Health at Tehran University of Medical Sciences and a senior fellow at the Harvard Humanitarian Initiative and a visiting scientist at the Harvard School of Public Health. Apologies for this kind of rushing over the introduction, trying to save time. I hope it works. So I'll start with a question to Dr. Abdu, actually. Hearing from the presentation and now trying to bring some operational perspectives from the ground, how do you see the current situation of the health system? And if I may say fragmentation, although fragmentation is not always a bad thing, affecting service delivery on the ground and the coordination between actors, and what does it mean for the sustainability of essential health services in the country? Thank you.
Thanks, Ibrahim. Thanks for having International Medical Corps as part of this important discussion. And thanks for Jacobs and Christina, who have set the scene very well, providing a very good background on what is happening in Syria. At operational level, I'm going to share the experience of International Medical Corps, where, first of all, the fragmented coordination have led to a duplication and gap in service delivery. If I may start with that pillar of health system, which is more important in Syria, where we have a huge need on the ground, and at the same time, a huge gap in terms of coordination that created a kind of duplication and gap in service delivery, seeing more services in urban area and very few service being provided in rural and hard-to-reach area, and that disparity has caused a lot of needs that left unmet across Syria. Beyond the service delivery that was affected at operational level, I think Fuad mentioned a lot about the health workforce, which was somehow severely impacted in terms of distribution of healthcare workers across board. And as mentioned previously, most NGO tried to cover the gap and adapt to the situation the way it was, creating environment that attract more healthcare workers on their side and leaving some of the health facilities without health workers, and creating, again, deepening the disparity between health services across board. Health information system was also very much impacted, and Jacobs talked very much about it, but at operational level, the sharing data was limited due to sensitivity across the hubs, but also the trust issues between partner sharing data, which created a poor situational analysis of the health system in Syria, making it harder to identify needs on time, but also to track coverage properly and deploy resources where they are needed. It's the same for health information system with not standardized tool that were used, indicators, data that are collected by different actors providing services, trying to adapt from the lack of the unified governance. Every partner, in every governorate with different tools, different means of data collection, which highly impacted the quality of data, but also the ownership of data. The coordination, the community-based coordination also is one of the areas that have been significantly impacted and created a disparity. We saw a greater role that was played by SARC, the WHO, trying to put together coordination among partners, although they provided significant support especially during the time of crisis, but it helped at some level, while at other level, partners were engaged in providing services based on their priority, but also based on the demand that come from donors sometimes, but also in their own evaluation, how they provide these services. Noting that prior to the crisis, there were no community health services, and this is something that was introduced during the crisis by some partners, including the International Medical Corps, as one of the adaptation to the lack of coverage in many areas. And having that structure being created in a parallel system, creating disparities in terms of how the package of services for this group is organized, and how the tools they are using could be unified, and so on and so forth. And these are things we hope with the new approach that has been presented by Christina will all be harmonized and be properly structured to be able to cover certain gap, at least during the transition phase that we mentioned. I will finish by talking about the effect on supply chain, the medical supply chain, which also created a parallel supply chain mechanism with every partners trying to cover the gap in the facility that they support, with poor oversight from a central level on availability of supplies and proper distribution of those supplies where they are needed, which caused a huge challenge and gaps in terms of medical services across board. I will stop there. I know we are mindful of the time, and I will come back later for other questions or comments.
Really, thank you so much. Yeah, we'll come back to discuss some of the points in this second round. But thanks for highlighting really the gaps in for me at least, your point around HRH distribution and the kind of having partners also trying to attract the same pool of human resources is key, whether now in the transition phase or in the future. And especially as also colleagues touched upon in the presentation, with the private sector emerging, also now you have another competitor kind of also competing over the same, unfortunately, limited pool of human resources. So thanks for that. And thanks also for flagging something that now will be maybe built on, which is the kind of the PHC and the community-based approach. This is another question for all of us. Would it stay? Would it be protected with the kind of the transition and beyond that? So this is another question. But let me now move on to ask Professor Fuad. Fuad, drawing on your work on health system resilience and also governance, how can you interpret really the current structure of the health system from a resilience perspective? Do you see, from what colleague presented, signs of either adaptive, but as you know very well, you are also working on this, maybe maladaptive kind of features and capacities within the fragmentation or the duplication? So yeah, the floor is yours, Fuad, please.
Yeah. Thank you, Ibrahim. Thank you very much for hosting me, and thank you, Egbert, also for organizing this event. I will extend my thank you to Christina and Elko for not just setting the scene, because I think this is like about bringing a lot of information and issues to debate. I guess I'm concerned about time, but maybe we need another session for that sort of conversation. But yeah, thank you, Ibrahim. Back to your question about the issue of resilience. And I need to put here two issues. The one that you mentioned when thinking about these three pillars, three elements of resilience, absorption, adaptation, and transformation. We're thinking always usually in that positive way, but sometimes we have many examples in transition and post-conflict periods of different crises in around the world, that sometimes that sort of adaptation turned to be maladaptation that lead to a maltransformation. But the other issue that I also want to address here is that when talking about health system resilience, we need not to disconnect this from other system resilience. So cannot see, now health system resilient by itself. That should be in, a sort of what's now in literature talking about multi-system resilience more than one system resilience. And then that's clear in the presentation of Christina about the issue of the finance, problem, the issue of, infrastructure when talking about the education and so on. So need to see that in that sort of scope. Back to that word of fragmentation that I hear it a lot today, and which I totally agree. There's a huge and different levels of fragmentation, talking about not just governance, but also health, information, health workforces, and so on. But let's also look into that component by itself. So although it can be seen as a very weak part of in the health system, but we can see that as maybe a survival mechanism. So when thinking about the issue of that allowed part of the system, to continue in Syria and to continue in functioning, through different localized governance, and that by itself, protect to some extent the flow of health services. Although it's not, by itself could be a solution, I mean, thinking about fragmentation, but that could lead to other question, which is about, the type of governance in that regard. So, the way that I think although I do agree with Christina about the government ownership, which is the model that, Syria witnesses in the last maybe 3-4 decades, that owning the structure, the system, the services, but also I think with that sort of destruction, the severe damages, not just in infrastructure, but also in health workers and information and other building blocks. I think it's now there's a need to start thinking of what could be a network governance, something that could go beyond one structure of governance that could, I don't know if it could be network governance or multiple governance that could be coordinated by the government itself, but that could something maybe later when going to the second route, thinking about, how to exit from, the other, from these sort of structural damages. Want to mention here about one of the mechanism that we saw it in the last 14 years, but also still seeing that, and also can play double role, which is the role of diaspora. We saw that in the last 14 years in different non-government controlled part of Syria, that the diaspora engaged a lot, the medical diaspora engaged a lot of providing services. And now we're seeing that in Syria after the liberation of doing so, but that issue of without again having that component of coordination, we could end up with having like a strong actor that's playing alone in that regard. the issue of one of the resilience, say, component also is that issue of pluralistic, services delivery with that sort of coexistence of different NGOs, UN agency that played a major role, in the last 14 years and still doing that. But the emerging strong role, although not totally emerging, because we saw the private sector role even in Syria before 2011, although it was not very controlled by the government, but there's a sort of controlling that, and now playing again like a sort of an independent player, and that's on one side, fill many gaps on services, but on another side, creating a lot of inequity, a lot of centralizing services in urban settings more than disputing that in other part. I will stop here because I think that's a lot of issues to discuss, but I will keep it to the second round. Thank you.
Well, thank you so much for that, really kind of bringing a lot of elements, kind of whether from the current situation or as a potential venues for recovery, whether what you mentioned about network governance, pluralistic service delivery, what's the role of each kind of a platform of services being delivered in the overall system. Now I'll move to ask our dear colleague, Dr. Ali Ardalan, an easy question to prioritize things and to tell us kind of really from what you heard and in line with all these patterns that colleagues described, where do you see the entry points, or what kind of, for you, the most pressing systemic weaknesses that must be addressed either before or in transition to recovery? Although I know we don't want to go into the debate whether recovery is a multi-phase things or a kind of a continuum, but how help us here. I'm really keen to hear your thoughts about what we discussed so far. Please.
Thank you so much, Dr. Ibrahim. Thanks to you and also Dr. Egbert for the webinar. And basically, thanks to dear colleagues Christina and also Ilko for the excellent presentation and setting the scene. The critical points were raised by Dr. Fouad, by our colleagues, dear colleagues, Dr. Abdu. Actually, there are the points that first I wanted to emphasize from all the previous presentations and comments that actually it's not an easy context. And basically is a country that has a widespread destruction of the social services, including health. A country that more than 50% of the health workforce, for some reasons, left the country, faces with massive displacement. And now, of course, with a good, as a positive signal, with waves of the returnees that needs livelihood, needs services, and everything. At the same time, we had basically, we heard a lot about the governance capacities and the actual fragmentation existed during because of the over the decade of the protracted conflicts. However, there are hopes and rooms for basically being positive. One of them is this seminar that FCAS has organized. I see also a very actually increasing trend of the discussions among the donors, academia, UN agencies about the Syria health system strengthening and recovery. And that's actually excellent point that is happening. The discussion of the recovery in Syria that Christina can explain better and more is not new for WHO and also the partners. I remember, at least myself, the first workshop 2018. At the time that basically even regarding, according to the donors red line, we couldn't use the recovery term as such. However, the discussion were continuing under the approach that we call it ARP, or Advanced Recovery Preparation, to be ready for wherever recovery is feasible. And it seems that's the time. So it's a long journey, difficult, non-linear, but anyway, we have to continue. Regarding the critical actually concerns that I would highlight, first is that ensuring the sustainability of peace and security. That's the key, actually, can be key challenge and also key enabler. We all remember that we couldn't use even the term of the recovery or even early recovery until we had the Security Council Resolution 2585 that gave green light to the international community to use that term. And that changed the actually narrative and some even action planning. Nowadays, the situation, alhamdulillah, is stable. However, this is the responsibility whole globe to ensure that the great nation of Syria will actually stay safe and secure. That will affect all the narratives and discussions we'll have. The second one is that we heard from the Christina presentation, we have more than 120, if I'm not mistaken, partners. Big, small, medium size, and with different type of the capacities and levels of the capacities and influence, potentially there are opportunities, all, if they work in a harmonized way. So that harmonization of the actors' efforts during transition, I think, is a key word. That requires governance capacity. This is also responsibility from the international community side to support the government of Syria to ensure that capacity exists, government-led, and basically all the partners can provide the needed support. And the last point I wanted to mention is about the issue of the predictability funds and financing systems. The big donors can change everything. If nowadays we receive basically positive signals from the key donors in terms of the supporting Syria health system and the recovery and nexus discussion. So if that continues, I think that would bring more hope and prospect to the future. Otherwise, for instance, nowadays with just funding 20% of the humanitarian fund needed, we have a serious challenge. So sustainability of the peace, harmonization of the actors' effort during transition, and the concern around predictability and adequacy of the funds. Thank you. Over to you.
Thank you so much, Shirley, for this priority, kind of setting the priorities and also the enablers. So some of them, as you clearly mentioned and rightly said, are within the global political determinants of peace and recovery. So thanks for reminding us of that. So maybe now I'm already in the second round of discussing recovery and then future looking kind of a discussion. And and let me double check with my dear colleague, Dr. Egbert, whether I'm happy to still move on with the discussion while we maybe look at the Q&As to pick some of the questions later on. So maybe I'll start and then we can have, because I see some questions already in the chat box. But I would like to start with the financing element. And we heard from Christina a very kind of interesting reflection on something now being discussed, which is the UHC Compact. And for background, for people who are joining us who might not be familiar with this system, so we're talking about a single-payer healthcare system before the conflict, where you have a free healthcare mainly for everyone and funded by the national budget. And also there were some opportunities before the conflict to try some social health insurance mechanisms. But now, as we all guess, it's a mix of maybe humanitarian assistance, but a lot of out-of-pocket payment. So my question to you is kind of also from a technical perspective, what kind of UHC model do you think might work? I know it's a very difficult question, but But what can you tell us about really the kind of the technical aspect of financing in Syria looking forward?
Is it for specific?
Yeah, I mean,
panelists?
Christina, or yeah, but please, I mean,
I
you
think
can,
Ali, Christina could have like a great input. I don't know.
I over to Christina and then I can continue.
Sure, I wasn't sure who it was addressed to. I
Yes,
think all of us.
exactly.
So, I mean, what I can say is at the moment, I don't want to reveal too much about the health compact just yet because it's under development and it's really for the government themselves to debut. But I would say that what's envisioned is a mix of approaches with an emphasis on starting with, of course, vulnerable persons, trying to protect against catastrophic health expense, and also, understandably so, looking at civil servants as well, potentially as a mechanism to pilot insurance as well. So I think there's a range of approaches, and I would say that again, without the compact will be available once it's debuted in December, and I think that that's on, I think 4th and 5th or 5th and 6th in Tokyo. And that there is also an understanding that there are multiple actors that can play a role, private sector, NGOs, the government, and that social insurance has a potential role to play. There's a lot of steps, obviously, between that right now and getting to that point. And what is also encouraging is the recognition, I think, on the part of both the Minister of Finance and the Minister of Health, that there will need to be phases in this process, and that what is most important perhaps in this is that we ensure sustainable, predictable approaches to this, that we don't try to go too far, too fast, too extensive, and then have the system collapse as well. So that the phasing of that and the predictability of that, and making sure that if there is an approach really driven by a PHC approach, and again, not just the primary healthcare center, but the PHC approach that also extends in all the way up to secondary healthcare and beyond, that those services are quality, accessible, affordable, etc. So I think the concepts, I would say, and I'm not a health systems expert, so but I would say the concepts and the anchors for a lot of what we talk about in the components of this are there. But the specifics, I would just appeal for our patients for about 1 more month, and then you'll start to see sort of how that plan is shaking out. But the last thing I will say also is just the recognition of the fact that health and education, at least on the part of the finance minister, are anchors to recovery, and really an intentional effort on the part of this government to at least try to ensure budget space that reflects the essential nature of those two sectors. And so it's not to say that there's not challenges ahead and that the mechanics of this aren't going to be hard. Of course they are. But I feel like there is a reasonable approach to this that really recognizes the complexity and also looks for the global approaches that have worked well in other settings.
Thank you so much, really. Even the highlights on the strategic direction at this moment is really key, and to help us understand, really, as you said, the kind of the willingness of the local authorities to move ahead with some maybe domestic funding and kind of improve, the share of domestic funding, and maybe pilot some financing model that would serve the vulnerable population and the wider population. So thanks so much for that. You touch upon something very important. The question is not for you specifically now, just to avoid confusion with colleagues and everyone. It's to all panelists, but please feel free to jump in to also answer that, is how to protect PHC. Now I'm moving to service delivery. How to protect Syria's health system, or kind of the PHC kind of being the cornerstone of the health system, as you mentioned, not just the centers, but as an approach to service delivery, while with a lot of funding and hopefully kind of funding coming, and also re-emerging of private sector, some successful models from different regions from the country might be wiped off, or maybe not kind of, protected. I can see Professor Fuad's hand, so please, the floor is yours too. help
Yeah,
us think
thank you.
about that.
Actually, yeah, I mean, I've tried to make some sort of reflection, also with the answering your question, Ibrahim, which is, I guess, when thinking about the issue of the approaching that PHT model, which is, it was embedded in the legacy of health system in Syria, which is, that was the approach before 2011, which makes it to some extent a bit easy when rethinking about the PHC system. Before 2011, more than 1,100 form of PHC centers, whether like a big or small, or function or non-function, but at least the infrastructure were there, and thinking about that, only now 23%, as Christina mentioned, function. That means we're having like a huge destruction. I'm trying to link that with my concern always about the health system governance, and how we can see that in the future, which is, led me to that sort of thinking about, functional approach of the governance more than structural approach. I mean, in that way, we're thinking about some functions that the health system governance usually, does, including, let's say, sort of clinical guidelines, essential health package definitions, what definitions we think about, the issue of, standards settings, what the standard that we need to have it, so the issue of surveillance approach. So all these issues of function more than the structure of, the governance itself, who control what and what and how. But we're thinking about how to unify that sort of functioning. And I think in that case, we need to, what we could do, building trust to that sort of local governance, thinking about how, I mean, people, what happened in the last 14 years is people were driven by performance, actually. They went to, some NGOs that perform better than others. So that sort of performance, that building trust, with local sometimes governance, could bring that issue of maybe phase one. I mean, back to this issue phase of recovery, phases, is to start doing that. So, and again, back to link with your question is, yes, in this case, that extended understanding of primary health care, as mentioned again by Christina, thinking about all that way, to including primary and secondary care, could be a good access, given that this is in the institutional legacy of Ministry of Health in Syria. Over.
Thank you so much, really, for the reflection. If we want to touch upon quickly other building blocks of the health system, maybe information system and workforce planning, we heard from Dr. Elko reflections and some work, like the study on that. Would you please, Elko, or any colleague, tell us a bit if you found some promising example that could be scaled up as part of the recovery process, or where do you see also the entry points from a workforce planning, from a health information system that really can be built on to move towards an integrated and resilient health system in the country?
Thank you,
I can
Ibrahim.
start.
But sorry, Abdul, you feel free to
No,
go
go
ahead.
ahead. Go ahead, Elko.
I'll keep it short, so maybe you can, yeah, then there's also time for you. I think a lot of relevant smart insights have already been shared. I very much agree with, on the one hand, what Ali mentioned also about harmonization. Harmonization is key from the donor side, of course, and that includes also looking at the non-traditional donors that are actually, we found, quite active in Syria. And on the other hand, yeah, also indeed recognizing the functional governance concept, I think, is really key. So if you talk about like good practices or something, it's difficult to say, but looking at like what's functioning in terms of information systems and governance actors that are performing in that domain. So we found these health directorates. It's subnational level, regional, district level, to be continuing. They've kept on functioning to varying degrees. And if you start building from there and focus on coordination based on trust and functionality instead of necessarily centralization based on hierarchy, then that's a good way to start. I would say in such a setting where trust is lacking and there's varying degrees of functionality. Yeah, I'll stop there. I think that's maybe an important lesson there.
It is actually. It is a.
Yeah.
It is an important lesson, and also, kind of, but sometimes also giving some autonomy to local health directorates and also some financial capacity. So it might start with trust and functionality, but also you can somehow delegate some of the power elements to the directorate. Sorry, I kept you waiting, Abdu. So Dr. Abdu, please, your thoughts on that.
I just want to highlight that there have been some investment made, although in conflict or not in coordinated way, but there are a lot of investment that were made during the conflict, specifically by NGOs and UN agencies, including WHO, and that can be used as an entry point, to scale up certain or sustain certain of approach that were used to cover the gap in terms of human resource deployment. For example, many NGOs, including IMC, have trained a huge pool of healthcare workers within Syria, and those can constitute already a pool of trainer to train others. To cover the gap, for example, in terms of mental health availability, IMC train all the healthcare workers on MHGAP, psychological first aid, and those type of adaptation measure can be a scale up, at least on the early recovery phase, to set a ground for a better health system in the future. But also, I'm trying to bring back the component of community health services that have been introduced during the crisis, but that it's a potential that can be explored further and see how that can at least cover a certain gap in terms of human resource and health workforce development. That's my contribution to that. I'm seeing we are over time now. Over.
No worries. Thank you so much. And I'll leave it to Dr. Ali to give us the reflection, and also if you'd like to say any kind of key reflections, because this will be the last point or the last contribution for this round of discussion.
So basically, reflection on the operational entry points. There are many. Classic one, health information system, training of the health workforce, rehabilitation of the existing health facilities, essential package of the health services, etc., and etc. And all of them are important, especially when you are still in the humanitarian situation. You have to whatever is possible, whatever that can provide the services right now to the affected population. But if we want to think a bit actually toward the sustainable long-term recovery, the baseline of all this discussion should be thinking about the model of care in the country. What kind of the health system we want for Syria, or Syria wants for itself, So what kind of the health system? How basically bold they want the PHC be actually considered in shaping the future health system? What kind of the services are going to be provided? What will be the role of the private sector? What will be the use of the actually public-private partnership approach in that future health system? Having that, if we know what we want, how that health system would look like, then whatever all those 120 partners will do make sense and will reach and actually to a same target. Otherwise, this one will train with this for that service, another one for another service and system. And finally, after 5 years, we'll have another crisis in Syria because of that fragmented support. Over to you.
Thank you so much, Shirley. Again, re-emphasizing the role of defining the strategic direction of the health system as a whole. Dr. Fuad, very quickly, if you'd like to add anything before we close.
sorry, I know we're over time, but I couldn't, resist that sort of the idea raised by Dr. Ali, about that's what Syrian wants, and I guess this is a very core question, but at the same time, this is not easy to answer that question, because then what is the mechanism for Syrians to decide, what they want to, and for their health system? And that's why, I mean, it's good to explore different examples, different, experience from other maybe settings, but also being in that sort, although I do strongly agree with the strategic plan, but need to think about it as sort of also phases, and being flexible to sometimes to be able to address unexpected outcome, given that we are in very, very volatile situation. And again, I would always, sorry for saying that, always to link health system with other systems, and we need to think, it's not a silo. We cannot work on that. The third issue and the last, we need to have also something, a new approach, new thinking to address that very challenging way. I mean, thinking about health information system. Well, maybe we cannot do integration, but maybe we can have like a unified structure of, health system, or maybe we could have like a sort of, I don't know, common indicators, something like start doing, that small issues could build, that long-term strategies, my dear Ali. Thank you.
Thank you so much. And this is remind us of, I think also Dr. Christina mentioned in the presentation, the people of Syria, and I like that. So I wrote it down. So really it's kind of serving the people of Syria first and then keeping that in mind. So with this note, I will close. I'm looking at Egbert looking at me, so I'll close probably at the screen. So I'll close the discussion, and thank you all really for the valuable contributions. Thanks.
And sorry
thanks.
for not answering all questions, in the Q&A.
I'll get to that. No, sorry. So thanks very much, Ibrahim, for leading these questions. As always, we are short in time with this kind of webinars because it's so interesting. And towards the end, there was a question among the questions that we can't answer, unfortunately, but is there a follow-up? And in particular, also with the Ministry of Health. This time it did not prove possible. There was just not time enough to organize it, but it does feel there are so many issues. We start exploring them, that there is definitely space and room and a need for a follow-up in one form or the other. So we definitely will look into that if that will be feasible. In terms of the other question, if the presentations will be available, well, at least they will be available through the website of Health Systems Global, where the recording of this session will be available, if not today, then soon after. If you have any questions, we have also given you the email address of our thematic working group. You can always post questions. It's a generic email, but it will lead to us, and we will try to answer you. Also, if you have any suggestion, please come forward. I hope you have enjoyed this session as I did. I think it's going back to Syria to see the difficulties, but also seeing the opportunities, challenges. But yeah, I think that there's scope, there's some optimism. And I must say, in global health, we're usually not that optimistic, and in particular not over the past few months. But today I feel a bit better. So thanks to all of you. And we hope till the next time. Okay, thank you very much.
Thank you so much.
Thanks, everyone.
Goodbye.
Everyone.
Bye.
Thank you. Bye-bye.